the past, present, and the future. My name is Dr. Wisdom, and I'm glad to have you tuning in to listen to what I'm about to share today. In our last class, I began to introduce the basic concept of glaucoma, and I began to say important salient points. Um, Today, I will want to take a step further, add another layer to the several layers I have been adding so far. But before I do that, I want to do a quick recap of the last lecture I had with you. Before that, I also want to appreciate those who are following us from India. Thank you for your feedback. Those who are following from Asia, thank you so much. Those from Ghana, United Kingdom, and Norway, thank you so much for your comments. Thank you for your likes. Thank you for your subscription. Thank you for your support to this channel, especially those from India. Thank you so much, and God bless you abundantly. So do well to subscribe, do well to like, and do well to follow the channel if you have not done so. And just in case you've done so, please share it with everyone. Share it on your social media handles. Share it to your loved ones. As you do so, remain blessed. So yes, last week I began to introduce the concept of glaucoma, and I said that glaucoma is the silent thief of eyesight, and then I defined glaucoma as a group of diseases that leads to the damage of the optic nerve. That glaucoma affects the optic nerve, thereby resulting to loss in vision. I also said last week that the optic nerve is the second of the 12 cranial nerves in the body, and is responsible for sending impulses to the brain, and any damage caused to the optic nerve cannot be regenerated. I also went further to say that the optic nerve is comprised of millions of nerve fibers, and these nerve fibers, they are responsible for transmitting visual information to the brain, and this is why the optic nerve is very, very important and should be preserved at all costs. Also, we looked at common risk factors that can lead to glaucoma, which is the commonest of them being elevated intraocular pressure. And I began to say that there's what we call the intraocular pressure. It is the pressure inside of the eyes, and if this pressure is above the normal limits, it can result to damage in the structures in the eyes. And then I also said that the normal range of pressure in the eyes is 10 to 21. Just as the way the normal range, the body has a normal range of blood pressure, the eyes also has its own normal range of pressure, and the normal range is 10 to 21. So anything above 21 is considered elevated and can result to serious damage to vision. So this is why we want to preserve, bring down the pressure and make sure that it is within normal range. I also said in our last class, I talked about the aqueous humor. So, and I began to give a little analogy that the aqueous humor is a fluid produced in the eyes, and I was able to explain it last week by saying that there are structures in your body that blood does not get to, because blood nourishes your body, but there are structures in your eyes which blood does not get to, but those part of the eyes also needs to be nourished. So the body produces a fluid called the aqueous humor. The aqueous humor, which is produced in the ciliary body, it flows through the posterior chamber to the anterior chamber, and then as it flows through, it nourishes those structures. So but then, because it's a fluid, if the fluid is produced in more quantity than needed, it can result to buildup of pressure, or maybe the fluid is being produced well enough, but it's not draining as fast as it should drain, which means there will be an accumulation or a clog up of that fluid, of the fluid in the eyes, leading to increased pressure in the eyes. So this is what we call the aqueous humor dynamics. And I began to say that this fluid being produced by the ciliary body and body pars plicata, to be precise, it flows through three major channels. The first is the trabecular meshwork, where 90% of it flows. The second is the cribriform meshwork, and the third is the iris. So the cribriform meshwork, about 10% flows through there, and just a little percentage flows through the iris. And then it then means that if the pathway for which this fluid flows out is clogged up, then there can be an accumulation of pressure. If there's an accumulation of this fluid, it results to increased pressure. Increased pressure results to damage of the optic nerve. Damage of the optic nerve results to loss in vision. and this is what we call glaucoma. So this is why it is important that you have a doctor who screens you for glaucoma, and just in case you have been diagnosed or there's a family history of it, it's important that you go for regular checkups so that we know where we are. So that was what this is a quick recap of what I taught last week. So this week I'm going to introduce a new layer, a new concept. I'm trying to break it down. I'm trying to be simple as possible because in this series, unlike other series where it has been more of professionals joining, but in this glaucoma series, it has been more of professionals are joining too, but also patients are also joining. That is, lay people are also joining. So I don't want to sound too technical. I don't want to sound too over there. I want to be basic as possible so that even patients or people who are just interested in the concept can understand what I'm saying. So this is why I'm trying to be basic as possible. So today I want to continue on the concept of glaucoma. Today is a part 2. So today we want to look at ocular hypertension, and what it is, and then we call it a wrap. So like I said earlier, in glaucoma, the major cause of glaucoma is that the pressure is high. But sometimes the pressure can be high, yet the patient does not have glaucoma. So this concept is called ocular hypertension. Ocular just means the eyes, and hypertension means that the tension is high. So ocular hypertension is a phenomenon whereby the pressure in the eyes is above 21 millimeter mercury, but yet there is no sign of glaucoma. So these signs are seen by your doctor. So your doctor can look into your eyes and then he's not seeing the signs of glaucoma, but then your pressure is high. So the condition we call that is called ocular hypertension. So, and it is important that we understand the concept of it and then know what to do about it. So in ocular hypertension, it is said that the age, people who are older have a higher risk of having ocular hypertension, and then a central corneal thickness of less than 555 is also a major factor in an indicator that one is susceptible to having ocular hypertension, and also a large cup to disc ratio can also suggest of ocular hypertension. So there are many other indicators for it, but then it is these few ones are the major ones we should look at and then begin to talk about. So the management of ocular hypertension is as same as the management of glaucoma, but then in ocular hypertension we give systemic drugs. Not systemic drugs, rather topical drugs, eye drops. Your doctor will give you an eye drop in order to bring down the pressure. And also the first line of treatment for ocular hypertension is selective laser trabeculoplasty. That is the first line of treatment. It's a simple treatment whereby laser is used to open up the trabecular meshwork of the eyes and then allow the fluid to pass through. So it is an inpatient, it's a very minor procedure that you can do and then go back to your work. 10-15 minutes you are done, and then when it's done you might not need to use your eye drop for about 4 to 5 years, as the case may be. So it is an important procedure and the first line of treatment in ocular hypertension. So that is that for ocular hypertension. So quickly, let us go over to glaucoma, which is our major emphasis. So the goal of the treatment in glaucoma is 2. The first is to bring down the pressure within normal range, and the second is protection of the optic nerve, because the cells in the optic nerve cannot regenerate. So we want to protect it as the best way we can, in order not to lead to further degradation of the cells there. Are we together? So currently research is going on how best to protect that. I'm going to be talking on that on the further series of this same glaucoma, on the current research that has been going on in optic nerve protection and optic nerve rejuvenation. So glaucoma can be classified into few classes. There is congenital glaucoma. In congenital glaucoma, the patient is born with glaucoma. So that's what we mean by congenital glaucoma or developmental glaucoma. And then there is also open angle glaucoma, and there's also what we call closed angle glaucoma. Now, this is the trick. In open angle glaucoma, the anterior chamber is open. The implication is that since it is open, the fluid called aqueous humor can flow quickly without restriction, but yet glaucoma is setting in. It also means that the pressure is within normal range, yet there is glaucoma. So in open angle glaucoma, the pressure might not be 21 in the upper limit. It might still be within the normal range, that is 10 to 21, yet there is still glaucoma. So just in case you walk to a clinic and then your pressure is checked and you see that it is normal, it is not also a guarantee that you do not have glaucoma or you will not have glaucoma. So in open angle glaucoma, the pressure is normal. The pressure is within the normal range, yet glaucoma is there. And then in closed angle glaucoma, the anterior chamber is narrow. So if it is narrow, it means that the fluid cannot flow as quickly as it should flow, thereby resulting to accumulation of this fluid, resulting to increased intraocular pressure. Are we together? So another risk factor. So one of the major risk factors for glaucoma is one, the intraocular pressure. So the higher the intraocular pressure, the higher your risk of having glaucoma. The second is age. The glaucoma is more consistent with those who are older than in young persons. So another risk factor is race. Blacks are more susceptible to having glaucoma than the whites. So if you are black by origin, if you are of African descent by origin, you must, as soon as possible, go and screen yourself for glaucoma, because being African as a race is one of the risk factors of glaucoma. And also a family history. If there's a family history, if someone has gone blind before, or if someone has had glaucoma before, likely some other persons will also have glaucoma. So it is important that every time you hear someone has glaucoma in your family, and even if you don't hear about it, it's a routine test that every patient is entitled to. Every patient is entitled to know their glaucoma status, because glaucoma, like I said earlier, is a silent thief of eyesight. In other words, you won't notice that your vision is going until about 60 to 70% of it is lost. That is when you begin to notice it. And remember, I told you earlier that any loss in vision due to glaucoma cannot be restored. This is why we want early detection. And also, people who have diabetes mellitus are also susceptible to having glaucoma. So there's a relationship between the increased sugar level and then glaucoma. So there's a relationship. And again, another risk factor is people who are myopic. So in myopia, rays of light do not fall on a point in the retina. They fall in front of the retina, leading to blurry vision. So people who have myopia, they find out that distant objects appear blurry to them, but closer objects are clear to them. So this is because the image of light, the rays of light entering the eyes, they do not form a sharp focus on the retina. They fall in front of the retina. So people who have this condition are likely to also have glaucoma. Also, people who are also hypertensive are also susceptible to having glaucoma. Also, certain drugs such as steroids, people who take steroids for long are also susceptible, or is a risk factor in having glaucoma. Also, genetics plays a huge role too, in most times in primary open angle glaucoma. So this is one of the few, and of course, family history. If someone has it, likely you might also have it. So this is just an avenue to sensitize the public and let them know that there is a thing called glaucoma, and that glaucoma is not a death sentence. Just in case you've been diagnosed of it, it is not a death sentence. If you are with the right doctor and then you follow your instructions, you are going to be fine. So, and that is that for the history. Now let's look at the screening. What are the screening we do for glaucoma? For instance, we are inquisitive. What do I do if I feel or I've been told I have glaucoma, what should you do? The first thing you should do is not to listen to people who are non-professionals. From my little practice, I found out that patients most times tend to believe those who are not practitioners than the practitioners themselves. And again, this is also a disclaimer that every time you see a drug that they tell you it cures cataract, it cures glaucoma, one drug cures diabetes, it cures hypertension, it cures cataract, it cures glaucoma, it cures 10 things in one, it is fake. The pathophysiology of cataract and glaucoma are not the same. They are two parallel lines. So anybody that tells you that a capsule or a herb cures glaucoma, cures cataract, he just wants to destroy you and eat your money. So the best treatment is found in the hospital, not in the roadside. Anybody coming to tell you that there's a drug that with this you don't need to wear glasses again, that with this you don't need to take drug for glaucoma, is just deceiving you, and then you are going to pay with your vision. So it's important that you consult a licensed and certified doctor and then know what to do. So now that we have said this, what are the tests we are to do in order to ascertain that one has glaucoma? The first test we do is what we call the visual acuity test. In the visual acuity test, we want to know how well you can see with each eye. So the doctor covers one of your eyes and then he tells you to read certain things from 6 meters or from 3 meters, as the case may be. He wants to know what you can read. So the gold standard is 6 meters, and then he wants to know what you can read. So the first test is visual acuity. The second test is to examine your pupil. So we examine this in order to rule out relative afferent pupillary defect. And then another test also for glaucoma is the color vision assessment, also the slit lamp examination. In the slit lamp examination, we want to look at your anterior chamber, we want to look at the general anatomy of the eyes and see if anything wrong is going. Also, we want to do an important test which is called tonometry. In tonometry, we want to look at the pressure of the eyes. The tonometer is an instrument that measures the pressure of the eyes. So there's no way you can know the pressure of the eyes if it is normal, above, or below normal limits unless you do tonometry. So tonometry is the gold standard for knowing what the pressure of the eye looks like. So every time you visit an eye clinic, it is a matter of must that your eye pressure must be checked. So tonometer is very, very important. Also gonioscopy is there, and then the most important is the optic disc evaluation, the optic disc examination. In this case, the doctor uses an ophthalmoscope and then he looks at the back of your eyes in order to see changes associated with glaucoma. And then there are also other tests we can send for. One is also the pachymetry. In the pachymetry, we want to find out if your cornea is thicker than normal or less thick than normal, because if your cornea is thicker than normal, it can give a false reading. If it's less thick, it can also give a false reading of your eye pressure. And also the gold standard, the chief of them all, is the OCT, optical coherence tomography. So I have done a video on OCT interpretation. Kindly do well to go through my channel. You see a video there on OCT interpretation. Do well to study it, do well to watch it, and then give me your feedback. So the OCT is the gold standard, or is the chief of them all, in order to track glaucoma progression. So this is just a tidbit of glaucoma for today. Thank you for joining me. In next week, we are going to add another layer, and then we'll keep making progress. So if you have any questions, you have contributions, or you have suggestions, do well to send me a message on this channel, and I'm going to reply you as soon as possible. Don't forget to subscribe, don't forget to like, don't forget to comment and share as you've been doing. Thank you so much. God bless you, and I hope to see you next week, same time, same station, for part 3 of Demystifying Glaucoma, the past, the present, and the future. I am Dr. Wisdom. God bless you abundantly.